large portion of patients where it wasn't cost effective. It really, many patients, I guess, did not use it, did not gain much from it, did not use it after a while. So I think we do need to be selective with patients that we offer home telehealth devices to. So this is the work that comes out of Boston, looking at home telehealth and some of the lessons that have been learned so far. So number one, telemonitoring is not plug and play. Patients will have problems. Patients will contact you about not knowing how to hook things up. You do need some support being available to the patients. And you do need support for the staff too. So there is a learning curve that needs to occur for telemonitoring. Number two, you need to integrate this ability with your EMR. If that doesn't happen, then somebody's going to be doing a lot of transcribing. Alerting capabilities are helpful. So it's helpful when someone downloads a bunch of blood pressure readings that it alerts you if something is an outlier. It could be an erroneous blood pressure measurement at that time. It's helpful to be able to look at that and identify that and remove those from the reporting that's given to the provider. Another thing that might be helpful is that with glucometer readings, it would be helpful to know when patients are checking a fasting versus non-fasting finger stick. Also, the different times of the day that they do their finger sticks, that type of reporting is helpful. The workflow that needs to be defined. Within the VA, the workflow right now for home telehealth goes from the patient to the care coordinator, and a lot of times the information stays with the care coordinator, and sometimes that information will get transmitted to the provider if needed. So the provider, for the most part, doesn't see a lot of things that happen with home telehealth. I think that's something that's a benefit to being providers. I mean, providers really don't want to have to go through 5 pages of blood pressure readings from the home monitor. We do need education for the staff and for the physicians on the evidence, just to get buy-in. May not be well received for the fee-for-service model. Again, I'm not quite sure how things happen in the private world in terms of home telehealth. I think that reimbursement is not what it should be. And again, not all patients are interested or appropriate for home monitoring. You still need real-time communication and relationship building. Patients and staff still like the rapport of a face-to-face, in-person visit. That's something that home telehealth, unfortunately, I think won't take the place of having a patient in front of you and developing that rapport. Patients will still need to come in periodically for different types of treatment, different types of care. With home telehealth, one of the emphasis is trying to educate the patients and trying to have them be managers of their own health. Patients are busy, so one thing is that we try to have them build the monitoring into their daily routine so that they report on a regular basis. And non-physician providers may play an important role in enabling this intervention. Again, we have the nurses, the nurse practitioners, clinical pharmacists, the PAs. They do play an important role in telehealth, and we do plan to utilize them more in this role. Some ongoing challenges: the lack of adequate infrastructure. Again, with the VA, this is really embedded into our whole healthcare system. One part really relies upon the other. Without all the pieces in place, it's really hard to have this type of system. Poor implementation, learning curve with patients and staff. There is a learning curve that needs to occur. Privacy and security issues, lack of physician support, monitoring fatigue. I think some of the studies did show that after a period of time, there wasn't much benefit gained from the continued monitoring. So there are some patients where they may be initially very excited about the home telehealth monitoring, but after a while, that excitement fades. And then we did talk about the cost effectiveness of patients. It may depend upon patient selection. So some of the ways that home telehealth can help, the problem stated is your poorly controlled diabetic patient doesn't bring his meter or blood sugar readings to the clinic, or you have a new diabetic patient and want to monitor their response to initial therapy without another face-to-face visit. Well, home telehealth can post blood sugar readings in the EMR, and also the home telehealth NP can help titrate your diabetic medications. The next problem, your patient with heart failure frequently ends up in the ER for decompensated heart failure. Home telehealth can monitor daily weights and warning symptoms before the patient ends up in the ER and make appropriate changes. One problem, your patient has elevated blood pressure but reports that their blood pressure readings at home are always normal. So home telehealth can post the home blood pressure readings in the electronic medical record. You also can put in a running BP average. The home telehealth NP can help titrate the BP medications if needed. Next problem, your patient suffers from depression and is being started on antidepressant. Home telehealth can monitor the patient's response and keep the clinician informed. So in summary, home telehealth is quickly becoming mainstream medicine, and with the VA, it is mainstream medicine and will be, like I said, will be spread to 100% of the VAs by next year. Although not for all patients, home telehealth has improved health outcomes and lowered utilization of precious healthcare resources. Home telehealth seems to have better outcomes when paired with care coordination. Benefits include improved access, less time, less travel for patients, and overall patient satisfaction has been very high. And this last video. This was actually 2 years ago.
The ability for us to connect to a veteran wherever they are, and really whatever the circumstance, allows us to provide care at a time where it could really be needed. So for example, following Hurricane Harvey, when the Houston clinics were very short-staffed, we were able to come in and we were able to use BBC to see patients on the ground in clinics in Houston. And I saw a patient who was being treated for an infected foot wound. And he had been on some antibiotics that hadn't been working, and because of the hurricane, hadn't been able to follow up to tell his provider that these antibiotics actually weren't effective. So as he was evacuating his house, he found himself in waist-high floodwaters, very dirty waters, and he noticed that his foot, over the course of the next few days, was hurting more and more. And this was particularly concerning to him because he was a caregiver for his wife, who has advanced metastatic breast cancer. And so he came into the clinic, and they said, you know, Dr. Hayworth is in San Diego, but come into this room, she would be happy to see you. And at first he was a little bit skeptical. He said, what do you mean I'm seeing a virtual doctor? But when he came in, we both realized that we had a really close and human connection. And he was able to open up to me about the struggles that he'd been having with managing the health of his sick wife, being not very healthy himself, that was a challenge. And to be able to discuss the challenges that he faced, and to be able to look at his wound and prescribe a new course of antibiotics, and to be able to do that all virtually was a really wonderful experience, and speaks to the power of telehealth to help and assist in the moment of a disaster or an emergency. I actually followed up with him yesterday, a week after I saw him, and he was thrilled to be able to speak to me. It was like I was speaking to any one patient in my existing panel who I know personally, who I've met face to face. And I asked him, how's your foot feeling? And he told me for the first time in weeks, he was actually able to walk on his foot. And he said that the toe that was previously red and swollen was now much less so. And he was able to get up and about. He was excited to be able to walk. And his wife had her first chemotherapy since the storm. And he had been able to take her to that and felt very good about his ability to provide that care for her. To be 1,000 miles from this patient and to feel like I'm in the room with him is a really powerful experience. And to be honest, it's not an experience I think I could have predicted I would feel until the moment of being on camera with the veteran in the room. I think once providers try this technology and when they see the effect it can have, and for myself to be able to really retain that emotional relationship with the patient has been the most meaningful.
So conclusion, telehealth is not in the future, it's in the present, and we're using it right now. So thank you very much. I'd be glad to take any questions now. Yes.
Yeah, you mentioned several times that the nurse practitioner can help titrate medicines or make changes. Is that based on a main provider having to give the okay for that? Does that person interact at the time with the provider? Does it depend on the severity of the patient or their disease management protocols for that? How does that intervention with the nurse
So the
practitioner?
NPs within the VA are pretty much independent in what their ability to do and ability to titrate medications. Providers are kept informed, and providers, they could choose to opt out of that, having the NPs manage the patients. Yeah, a lot of times it's invisible to the provider for the NPs to monitor the patients and to titrate medications. So in my case, I think it's a great service. Yes.
I was curious how you started selecting your patients, because we have obviously an expensive home operating system is $39 a month. You said 1%. How was that selected?
Yeah. So for the home telehealth system, it's really focused on those high utilizers of the healthcare system, those that have high morbidity, high mortality rates. It's that list that initially I showed with CHF, poorly controlled diabetes, poorly controlled blood pressure, those with who are not stable mental health conditions. So it's really focused on those patients where we expect them to have a high utilization of healthcare services, high morbidity, and really try to focus on that group there.
I also like to add that we don't just admit patients just because they have diabetes. They have to be like the A1C is greater than 9 and
That's
above.
okay, yeah.
And they are their blood sugar readings are unstable. That needs to be titration. So those are the type of patients. The patients like 6 or 7 A1C, we don't get into program. It's just too expensive for them.
Right, so you're basically all diabetic patients, A1C over 9? Or
Over
just...
9, and those are newly diagnosed patients. The provider wants to titrate their insulin, so we get them into the program. Those kind of things. It's not for everybody.
Thank you.
Yeah, so for the patients who have A1C over 9, we do try to publicize this program as much as possible, but it is a voluntary program for the patient and for the provider too. So we try to promote as much as possible for these patients, but again, we do rely on the providers to refer patients.
We have another question from our teleconference.
Oh, yes.
Go ahead, Jim.
Thank you for letting me sit in. And by the way, this was a spectacular presentation. Really, the work by Chumbler with the 2 admissions or ER visits showing that big drop alone is something that I don't know that everybody has focused on in the past. And with, I don't know if everybody knows, I was with Kaiser Permanente. Our big problem was getting someone accountable to handle even basic things. Some of these people only need more metformin or sulfonylurea or a little more insulin, but they don't get it because people aren't held accountable. So this telemedicine would allow you to focus on one practitioner handling a bunch of things and being accountable. By the way, I just want to mention to you that both WebEx and Zoom were tested today here, and with Scott Flynn and Dr. Conan's using these technologies, with the sound as it came in was perfect, and they showed the slides, and I even saw some of the for those thinking they may want to be able to broadcast this either locally or farther, it does work, and it can go ahead. That's my only comments. Congratulations, I think you're doing great.
Great, thanks. Thank you. Great to know that technology does work sometimes.
Can we
To your
hear from
point-
others who have tried this or not? So Kaiser, you use it or you don't?
We use different form. We've had video visits for quite some time. It's been a few years since I've been involved with that, so I don't know the, am I not loud enough? I don't know the exact numbers with our video visits right now. We make that available for all of primary care. We do have a separate care management department that does several chronic conditions. Our biggest one is diabetes, and we have been using remote glucose monitoring that interfaces with our interfaces with our electronic medical record system. Right now, I think our biggest challenge is the resources to help the patients connect with it, because ours is a Bluetooth to meter, so smart device, Bluetooth connects to the meter, goes through the One Touch Reveal app. And so it's interesting to see the other options that are maybe a little bit more expensive, but also a lot more user-friendly, it seemed like.
So Wayne Chen, Blue Shield?
Yeah, hi. So when I worked at Alignment Healthcare, not at Blue Shield, we also had a home remote monitoring system. There's a partnership between Samsung and Alignment Healthcare. And we had our care coordinators monitoring these remote monitors, including glucose, for example, and blood pressure, not only on a daily basis, but also on the weekends. And actually, we had physicians and providers taking calls on the weekends. I'd log into the system at 8 a.m. and then see whose blood pressure out of control. And actually, we'd make video calls or telephonic calls depending upon what the member was receptive to. And I think overall, we achieved reductions like 20% across ED utilization and just unexpected admissions, for example. So we had a positive effect.
And are you using it at Blue Shield?
We have a different kind of approach to telehealth. Yeah, would you like to talk about that? We use, we have different vendors that we're currently partnering for Teledoc and even Heal, for example. Even our behavioral health vendor, Magellan, they have their own behavioral health program as well. So I think we have different approaches. We're not fully integrated, but we're definitely looking at this.
Ria Kulacharam from Health Partners, please.
Yes, so I think 3 or 4 years ago, we started remote patient monitoring for our CHF patients. We did an IRB-approved study for 400 patients, and we found in our intervention group, there was a 35% reduction in hospitalization. We also found 57% reduction in the admission, and we haven't expanded that program yet, but we're in the process of that. And then in our Nevada market for healthcare partners, we are currently expanding a program for remote patient monitoring where we have 4,000 patients now, and we are seeing 68% reduction in ER visits.
Wow.
And 52% in hospitalization. So they're very happy. They're like, can you start enrolling them faster? Because the flu season is coming. So I think, from our experience, and Lisa is here, she helped me with the CHF program at Healthcare Partners. And our experience is it really works, and you're right, when you said it depends what kind of patients you enroll into the program and how connected you are internally as an organization. If you fully depend on your vendor, it may not be the best idea. I think there should be some skin in the game from both sides. So currently we are actually doing a study, a randomized controlled trial for high-risk patients with multiple comorbidities. And it's called Project Trident. And the beauty of it is you can actually test out for your patient population, and it's free of charge. So you can enroll patients in that huge study, and hopefully RAND will be analyzing the data.
All right.
So
Just a quick follow-up question about that. How long did you follow your CHF patients to look at that reduction in admissions? I noticed you mentioned that you saw an initial reduction, but as time went on, it came back to baseline. Did you see the same thing, or how long did you follow?
So good question. So we actually followed them for 12 months, and we are still following. So one of the most, what I would say is, it really works. It's important. 3 months may not be enough time, but 12 months, I don't know if that's the, right time, but what we did is, we monitored them now for almost 2 years post that, and we found that they still show a better reduction in hospitalization, and they also know what questions to ask, and they know how to self-manage. And also we saw a mortality decrease in the 2 groups. So I think, there's a lot of, and quality of life, so we have that information.
Great, are you gonna publish it?
Yes, it's in the process of being published.
She needs
Again,
Alan's help
maybe
with
we'll
that.
work with Rand.
So Carol Peden from USC Keck School of Medicine.
Can I shout?
Yes.
So from the purely provider aspect, there has been challenges because until very recently you haven't been paid for this. But I think forward-thinking providers have just decided to, take it on the chin because we want to give the best care for our patients. But there's still challenges because one of the things we're doing is following up our patients virtually. But we have patients who come from Nevada, and we can't do that because we can't have our physicians treating them in a different state. So there's all sorts of things that still haven't quite caught up. But I think, I'm sure most of the organisations in the room are just getting on with it because for all the reasons we've discussed today. And we're actually doing it for some kind of strange and wonderful things like speech therapy, which works very well in this environment.
Yeah, a quick comment about paying for it. At Blue Shield, we do have a telemedicine payment policy, and we do reimburse for it, so.
And in fact, actually, I didn't say, but many of the insurers are being very supportive and forward-thinking because that this is better for the patient.
I just wanted to go around the room and ask the people who do have the telemedicine about the cost. The VA, the cost, is that borne by the patient or by the VA, and et cetera, going around?
The initial startup cost.
So at the VA, our costs are borne by within the system itself. So within the VA, we pay for all the equipment costs. The patient does not pay anything for the cost.
Yeah, for us also, the patient does not pay anything. We're a capitated managed care organization, so we pay, for the CHF patients, we are paying $45 PMPM, and for Project Trident, we are paying, I think, around $56 PMPM.
Yeah, at Blue Shield, our teledoc program is zero copay for our Trio ACO members, and for our other members, it's a regular outpatient visit copay. And for our telemedicine reimbursement policy, we're reimbursing at the regular rates for the telemedicine visits. So you would expect.
But is there any cost to the patient for the equipment?
No.
And which patients are eligible, Scott?
All. Yeah, the only difference is, again, Trio ACO patients have zero copay, and the regular, and all the rest of the members have the regular copay that they would pay for office visit.
So could you talk about, as we're about to wrap here, we're at the top of the hour, just one last question. Can you talk about applications for your mental health patients and PTSD? It seems to me that that's been going for a long time in the VA.
Right. So our last program that we're using, Video Connect, actually that is the area where we're going to have a large use in mental health. It's really being able to see the patient on direct video. That's where the psychologists, the psychiatrists, we're currently doing that too. Currently doing that locally too, because I guess in some of our facilities it's really hard to recruit mental health providers. So we've been using this to treat our mental health patients at different clinics. It's really provider-based, you know, whatever, it's really the same as an in-person visit, but it's on video.
So what an exciting topic. Thank you so much. That was very impressive. We'd love to learn more and do more in this area. Very, very appreciative of your presentation. Thank you. So once again, we'll see you back here on the 4th Thursday in September. And same time, same place, just the 4th Thursday instead of the 3rd. So that's September 26th, we'll see you back here. Thank you.
Now I work commercially, so I've for Southern California, so I've worked for county down in San Diego. Where did you work at? But never in Harbor City. Okay. I was at Subway for the Harbor City area for 7 years. I was part of
As we're thinking about our September I was actually, I wrote down. Good job. Good job.
Thank you.
Very interesting.
I hope you thought that was valuable.